Hello, everyone, and welcome to today's webinar, Implementation of Helicobacter Pylori Stool Antigen Testing in a Large Metropolitan Center, a Prospective Comparative Diagnostic Trial. I am Michelle Ashton of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more about our sponsor, please visit www.diasorin.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. Our speaker will answer your questions via email following this webinar. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education's Credits tab located at the top of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Dylan Pillai, the Professor of Pathology and Laboratory Medicine at the University of Calgary. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Pillai, you may now begin your presentation.
Okay, thanks, Michelle. My name is Dr. Dylan Pillai. I'm a medical microbiologist at the University of Calgary, and today I'm going to talk to you about the implementation of Helicobacter Pylori Stool Antigen Testing in a large metropolitan center, a prospective comparative diagnostic trial. So the objectives I have for today are to firstly gain understanding of H.pylori testing options. Second, describe challenges and benefits of utilizing H.pylori stool antigen testing. And finally, demonstrate how to effectively consult key clinical stakeholders in the implementation of this testing. I have one disclosure. I have received unrestricted educational grants from DiaSorin. So let's get right into it. Helicobacter pylori, or H. pylori, is a gram-negative, spiral-shaped bacterium that infects up to 45% of the global population, especially in developing countries. Most of these infected individuals are actually asymptomatic, up to 90%. However, the bacteria can cause chronic active gastritis, peptic ulcer disease, and gastric adenocarcinoma, as well as mucosa-associated lymphoid tissue lymphoma, or MALT lymphoma. These are cancerous conditions. Eradicating the bacterial infection cures the gastritis and can prevent some of these long-term complications. The risk factors related to H. pylori infection include crowded living conditions, poor sanitation, and low socioeconomic status. And this is perhaps why it is so prevalent in developing countries. So where does H. pylori or Helicobacter sit in the family tree? As you can see here by the arrow on the right-hand side, H. pylori is nestled here amongst all the Helicobacter genus, most of which are non-pathogenic to humans. However, certain species, such as Helicobacter sineadi, have been associated with bacterial infection of the bloodstream in immunocompromised individuals. And as you can see at the bottom of the tree, Helicobacter is closely related to another organism, Campylobacter, which we know well causes diarrheal infections. One of the classic features of Helicobacter as a genus and Helicobacter pylori is the production of urease. So urease production is indicated here by this bright pink fuchsia color you can see in the tube marked B. And this particular agar, Christensen's urea agar, results in a pink color when urease breaks down breaks down urea for the production of ammonia and carbon dioxide, which alkalinizes the media and causes this color change. So going back to Helicobacter pylori, ruling out H. pylori is required for the diagnosis of functional dyspepsia. Screening tools with non-invasive methods, such as the urea breath test and stool antigen testing, is preferred where the incidence of gastric complications are low. More severe disease requires invasive testing via endoscopic evaluation and ultimately biopsy. Gastric cancer is actually the third most common cause of cancer mortality, with over 700,000 deaths globally in 2012. And therefore, you can imagine that screening and eradicating H. pylori as one of the causes is essential. So peptic ulcer disease is the classic presentation of Helicobacter pylori. And while I said that most patients are asymptomatic, some patients experience symptoms like dyspepsia or fullness or upper abdominal pain. And in some cases, as I mentioned, this can develop further into neoplasia or cancer. These ulcers, as you can see by this cartoon, are essentially a breakdown of that mucosal wall that protects the stomach, and in some cases, the duodenum as well. Here you can see an example of a gastric ulcer and a duodenal ulcer. And on the right-hand side of the slide, we can see, again, a cartoon of what the bacteria essentially does. It adheres to the mucosa in the ulcer. And there's a gene called the cytotoxin-associated gene, or CAG-A, which is thought to be oncogenic. And of course, as I mentioned below, the classic feature of this organism is the breakdown of urea used by the enzyme urease for the production of ammonia and carbon dioxide. An important feature of H. pylori is the fact that it has become drug resistant to the antibiotics that we currently use to treat H. pylori. This slide shows that, for example, in the United States, there is more than 15% resistance to clarithromycin for first-line treatment for H. pylori. And in the case of Canada, you can see that over 40% of isolates that have been tested are resistant to clarithromycin, and over 30% on the y-axis are resistant to metronidazole. These are both very important drugs, and indeed, resistance to H. pylori has been deemed by the World Health Organization to be a priority 2 or high need for new antibiotics, in line with organisms like vancomycin-resistant Enterococcus and methicillin-resistant Staph aureus. So as you can see, H. pylori drug resistance is a major problem and an emerging issue. So what are the diagnostic tests that we use to detect H. pylori? And this table essentially breaks it down into non-invasive methods and invasive methods. Under non-invasive methods at the top, we have serology. While serology is widely available and inexpensive, the positive result may actually reflect previous infection and not current infection. So that's not very useful for the screening of H. pylori in a population where there is a high prevalence, for example, because it may essentially be describing previous infection. The urea breath test has good sensitivity and specificity, over 95%, with high negative and positive predictive values. This is a useful test for screening. However, false negative results are possible when the patient is on proton pump inhibitors, for example. And there are some difficulties in performing this test in certain individuals, for example, young children who can't comply with the instructions. Moving down, stool antigen test, again, a very highly sensitive and specific test with good positive and negative predictive values, with perhaps the caveat that here the disadvantage is that some patients may not like to collect stool and provide stool, and that may be an issue. Invasive tests, as mentioned before, include biopsy, coupled with histology, or a rapid urease test, both of which can be performed on the biopsy material. In some instances, culture is required, as seen at the bottom, because culture enables the detection of antibiotic susceptibility testing, which may be important in patients who fail eradication treatment. So what's the gold standard for testing? Currently, in the literature, and typically a composite of biopsy findings, a rapid urease test, and or culture can be used as a gold standard, with no single test being really conclusive. And in many studies, when 2 of these 3 tests are positive, they're considered to be a gold standard positive. So that's something that's seen quite often in the literature. This is what a biopsy stain typically looks like. And in the bottom right-hand panel, you can see an immunohistochemical stain of the gastric material in the biopsy with that reddish hue, identifying areas that are infected with the Helicobacter pylori organism. The other panels represent other stains that can be used, such as hematoxylin eucin in panel A, Giemsa, and a Warthin starry silver stain in panel C. The rapid Urease test is an indirect test of H. pylori based on the presence of urease in the gastric mucosa. It does require biopsy material, and it has the advantage over serology in that it only detects the presence of an active infection. However, it is an invasive test requiring endoscopy. The test requires a sample of the mucosa or mucus that is added to the tube or gel, and that's how the detection of the urease enzyme, as I've mentioned, which is classic for Helicobacter. In the next slide here, I show some examples of 3 popular commercial rapid urease tests that are used, including the CLO test and 2 other tests. The basis of this test, again, is the breakdown of urea into ammonia and carbon dioxide, which alkalinizes the media and produces this positive pinkish or fuchsia color here you can see in the CLO test. Another screening test that's used that's non-invasive is the H. pylori urea breath test. So for this test, patient preparation is required. Firstly, the patient cannot be on antibiotics for up to 4 weeks. No use of bismuth or Pepto-Bismol, for example, for 2 weeks. And the patient should be off of proton pump inhibitors for 14 days, and no antacids or antihistamines for 24 hours. Additionally, the patient should not have eaten, drunk, or smoked anything in the last 4 hours. The patient is asked to drink a solution containing the labeled urea and wait approximately an hour. H. pylori breaks down the labeled urea into ammonia and carbon dioxide, which is labeled, and the patient breathes into a tube where the labeled carbon dioxide is measured in the exhaled air. As you can imagine, these instructions are difficult to follow for young patients under 6 years of age, or elderly patients with difficulties, again, complying with the method here. H. pylori stool antigen testing is another screening method that's available, and here again, there are patient preparation steps: 4 weeks of no antibiotics, no bismuth products for 2 weeks, and no proton pump inhibitors for the same amount of time. The preparation is simple, however, because the patient essentially takes home a collection container and instructions from the doctor's office and collects the stool samples and delivers it to the lab as soon as possible, ideally within 8 hours, or if there are any delays, the sample would have to be refrigerated and brought in within 72 hours. The test is an enzyme immunoassay that detects antigens in the stool. And some patients may not be comfortable handling and storing their own stool. However, there is no requirement for preparation as with the urea breath test. So comparing side by side the urea breath test and the stool antigen test, you can see that the urea breath test does require an appointment with certain patient preparation steps that are required, such as fasting. There is a 1-hour lab visit that is required for the urea breath test, whereas the stool antigen test, essentially, the sample can be collected at home. And we're dealing here with breath sample versus stool samples, and there's this non-suitability for patients under 6 years of age for the urea breath test, whereas the stool antigen test essentially can be performed for all patients who can provide a stool sample. The performance characteristics are the same. However, false positives can occur with certain bacteria, such as Pseudomonas or Neisseria for the urea breath test, and false negatives with low-level infection or bleeding with the stool antigen test. And in our setting, we have noticed a difference in cost. And this cost includes labor and reagents for testing, but does not include test administration for the UBT. One note about children, this publication in 2003 compared the urea breath test with the stool antigen test for the diagnosis of H. pylori in children. And their conclusion was essentially that the sensitivity and the specificity, as well as the positive and negative predictive values, were identical, essentially, or similar between the urea breath test and the stool antigen test. The authors conclude that both tests are appropriate for diagnosing H. pylori infection in children. However, as noted, with children under 6 years of age, compliance with the urea breath test is not possible. It's important to note that the urea breath test is more resource intensive. And what I mean by this is that appointments are required where the patient must come into a service center or a laboratory facility and require staff time for the administration of the test. The test also may require time away from work for patients, and this may be potentially disadvantaged to low socioeconomic groups where the prevalence of H. pylori infection is in fact high. And the disadvantage essentially is that these patients have to take time away from work, whereas with the stool antigen test, the patient can provide the stool sample when it's convenient for them. So who should be screened? If we look at low prevalence settings like the United States and Canada, essentially any patients that are symptomatic with dyspepsia can be screened with non-invasive methods. However, high-risk patients, those who are older, with high family risk factors, or from an area with high rates of gastric cancer, or patients with red flag symptoms such as bleeding, should be subject to endoscopy and more invasive testing. So in our center, we conducted a prospective diagnostic trial comparing the UBT to the stool antigen test. And the motivation for this was that we had more than 50-day waiting periods for the urea breath test due to a lack of patient service centers to administer it. The study was conducted in Calgary in Alberta, a city of approximately 1.3 million people with a centralized laboratory system. And a total of 150 patients were agreed to undergo the urea breath test and consented to provide a stool specimen simultaneously for stool antigen tests. So these patients essentially were consented and volunteered to provide a stool antigen test while undergoing a UBT so that we could compare them side by side. The two assays here in question that were used were the UBT kit, the Heli kit, as well as the Diasorin Liaison XL H. pylori stool antigen monoclonal chemiluminescent assay. So the stool antigen test was performed on an unpreserved stool and run on a high throughput antigen detection system. The system, as I mentioned, is the Liaison assay, the Liaison H. pylori stool antigen CLIA test, which uses a monoclonal antibody, and the result is available within 24 hours of stool collection. The antibody is a monoclonal, which is important, and that's directed at the flagellin A protein, which forms part of the flagella of the bacterium. So this is essentially how the test is run. You can see on the left-hand side, there's a specimen preparation stool extraction device that's used to collect or to inoculate the stool specimen. And in the center, we see the Liaison XL analyzer. This is the chemiluminescent analysis that's performed. And there's essentially 35 minutes to the first result. It's a fully automated testing solution. And stool as well as serum samples can be run together on this instrument. So there may be other tests that are performed. And the results are qualitative and produce results at roughly 170 results per hour. In our own experience, we have found it important that there be training on sampling technique, and that is essential in order to inoculate the correct amount of stool into the system, and that instrument calibration and decontamination are essential from time to time in order to ensure that the results and the values obtained are consistent throughout the year. An important note here about specimen stability. As I mentioned in an earlier slide, samples should be ideally refrigerated between 2 to 8 degrees Celsius for up to 72 hours. If the sample cannot be tested within that 72 hours, stored samples can be frozen at -20 and then tested after that. The sample extract is stable up to 8 hours at room temperature, 72 hours refrigerated, up to 12 weeks frozen. And generally freeze-thaw cycles, obviously, of the sample extract and definitely of the stool sample are discouraged. The urea breath test in this study was the Helicobacter, a breath test that was performed to detect the H. pylori bacterium. It's a non-invasive, non-radioactive method and uses a convenient breath test kit for the diagnosis. And it's safe to be used on children over the age of 6. So here are the results of the trial. As I mentioned, 150 patients volunteered to provide both urea breath test and stool antigen test. And essentially, 148 out of 150 patients had identical results, either positive or negative, for the stool for H. pylori. So this, using the urea breath test as a gold standard, in this particular case, the sensitivity of the stool antigen test was 96.3% with a specificity of 100%, which leads to a positive predictive value of 100 and a negative predictive value of 99.2%. The disease prevalence or the positivity rate in this particular study was 18%. One of the two discrepants that was UBT positive but stool antigen test negative resolved after repeat testing on the stool antigen. So this leads to about a 98 to 99% agreement between the two tests. We did look at, in the trial, the use of specific antibiotics for the treatment of H. pylori. 38 out of 130 patients where we had antibiotic information had received an antibiotic associated with H. pylori in the preceding 12 months. However, some of those antibiotics may be linked to other disease states such as ear infections or pneumonia. We cannot be 100% sure those are related to H. pylori. Out of the 38 patients that had received those antibiotics, 37 had concordant results between the UBT and the stool antigen test. Of note, 6 out of the 130, or 4.6%, had received a specific combination anti-H. pylori treatment. And all of these, 6 out of 6, had concordant results between the two, which was encouraging that the stool antigen test and the UBT test provide concordant results post-treatment to demonstrate successful eradication, which is done routinely. So as a result of this study, implementation was discussed, and we consulted key stakeholders in the arena, gastroenterologists, our clinical chemistry colleagues, as well as our medical microbiology colleagues. We looked at the literature and guidelines that were available. And as I said, the major motivator to change testing was the wait times, which were currently greater than 50 days due to lack of space. Cost as well was noted as a major consideration in our single payer model with a fixed budget for testing. So in scanning the environment for the literature evaluating UBT as well as stool antigen tests, we noted this important study in 2009 from Barcelona. Here, patients with greater than or 2 positive test results were considered to be true positives. And the studies that were done on these patients included the rapid urea test, histological examination, the urea breath test, and the stool antigen test. These authors concluded that the sensitivities and specificities of 90% and 93% for the stool test and 90% of sensitivity and specificity for the urea breath test. Ultimately, the authors concluded that the stool antigen test and the urea breath test were essentially equivalent non-invasive options. Another study published out of Bologna, Italy, with the specific stool antigen test used in our study, looked at therapeutic monitoring compared against stool antigen test to urea breath test. And they found that the agreement was in 58 total tests done, there was essential agreement of approximately 98.3% between the UBT and the stool antigen test. Again, encouraging that these tests perform in an equivalent manner. So what do the major guidelines on testing say about stool antigen testing versus urea breath testing for H. pylori infection. Firstly, the Maastricht 4 Florence Consensus Report concluded here in red that the diagnostic accuracy of the stool antigen test is equivalent to the urea breath test if a validated laboratory-based monoclonal test is used. Turning to the United States, the 2018 Houston Consensus Conference recommends that only tests that evaluate for active infection, such as the urea breath test, the stool antigen test, or histology, are used for post-treatment confirmation of eradication. And this was grade 1A evidence. And closer to home, the Canadian Agency for Drugs and Technologies concluded that the EIA-based and ICA-based tests using monoclonal antibodies were comparable with endoscopy and or the urea breath test to determine the results of H. pylori eradication therapy. So we see close alignment of major guidelines on the use of the stool antigen test and the urea breath test for screening. We turn to laboratories with similar patient populations and similar volumes. And here at the Mayo Clinic, we see circled in red that for patients without red flag symptoms between the ages of 3 to 54, that either the urea breath test or the stool antigen test are used to screen for H. pylori. So what conclusions could we draw based on our own study and the literature, as well as guidelines and some of our peer laboratories across North America? Essentially, we concluded that based on our data of 98.7% equivalence between the two tests, the urea breath test and the stool antigen test, and 99.2% negative predictive value and 100% positive predictive value, the implementation of stool antigen test in our region was recommended, especially in view of the wait times that were required to obtain a urea breath test. Furthermore, a revised algorithm was required in order to advocate for the stool antigen test to improve the access and achieve satisfactory clinical outcomes. So the current algorithm in our particular region here in Calgary was that if there is suspected dyspepsia here at the top, without alarm features such as GI bleeding or progressive dysphagia, persistent vomiting, then a medication review would be offered. If there was no offending medication such as non-steroidal anti-inflammatories, which can cause peptic ulcers, then baseline investigations are done, such as a CBC, ferritin, celiac serology, liver function tests, as well as an ultrasound. And then moving further down, if these all were normal, the current algorithm required the urea breath test. However, with the advent of our study and further review of the literature, this was changed to the stool antigen test to improve access. However, if a request for UBT were made, these were triaged by the microbiologist on call, and the UBT is still permitted if the stool antigen was negative 3 times, or if the patient was unable to provide a stool for whatever reason in the correct condition, or if the result of the stool antigen test was equivocal, the UBT was still available. So what actually happened? Here are some of the post-implementation data from our own region. You can see in the red line that the volumes of the urea breath test went down as we changed our forms to accommodate the stool antigen test, and the stool antigen test volumes increased from a baseline of less than 100 up to now a steady state of close to 2,500 tests per month. So the changes in the screening algorithms went into effect and had the requisite impact, which was to switch the need from the urea breath test to the stool antigen test in order to improve access. And the wait times for H. pylori testing did go down as expected, from an average of 50 days down to essentially within 24 hours or as soon as a stool sample could be provided. So this was an important impact that we wanted to measure. Another important impact was the cost to the laboratory. So these were the monthly savings pre and post implementation of the H. pylori stool antigen test. So as you can see, as the H. pylori volumes hit a steady state of close to 2,300 to 2,500, and the UBT volumes decreased in those cases that still required it, we accrued monthly savings of close to $11,000 in this particular setting. And this only includes reagents and labor, does not include costs outside of the laboratory. So in summary, H.pylori stool antigen testing provides, in our setting, equivalent results to the urea breath test in our population tested. And the replacement of the urea breath test by the stool antigen test as the primary screening modality was driven essentially by our switch in the algorithm and our need to improve wait times and reduce costs. And these were achieved in our setting. Early utilization data suggests, interestingly, that by switching to the stool antigen test, there has been improved access to low-income areas of the city where the prevalence of H. pylori is high, and there were difficulties, presumably, in accessing the urea breath test. We believe that the urea breath test is still warranted where the stool antigen tests are equivocal or patients are not willing to provide stool samples, or as mentioned, there are persistent symptoms in spite of negative stool antigen tests, and an endoscopy hasn't yet been performed. Further evaluation of the stool antigen test is ongoing in post-treatment situations, and this may be important to gather important information about eradication. So with that, I conclude my talk. I thank you for your attention, and goodbye.
Thank you, Dr. Pillai, for your informative presentation. As a reminder, our speaker will follow up with any questions you have submitted via email following the webinar. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. Until next time, goodbye.